Hi, welcome back to my channel. In this video, I'll be discussing about the drugs used for the treatment of rheumatoid arthritis. So first of all, you should know like the basic pathology that goes behind rheumatoid arthritis. So what really happens is, basically, it can be induced autoimmune disease, and there is a predilection for HLA DR1 and 4. So what happens is, in this disease, we have normal synovial joint, and here we have our synovial membrane, and here we have the synovial fluid. Okay, now in this what happens is, this arginine, it is converted into citrulline. Now this citrulline is something which is responsible for the proliferation of the synovial cells, and then this synovial membrane, it gets thickened. So synovial membrane, it gets thickened, and there is basically an inflammatory condition that happens, that is induced by autoimmunity. So this gets thickened, and then a lot of since it's an inflammatory, and a lot of cytokines come, like TNF alpha, then you have some interleukin 6, interleukin 1, and many others. So CD 80, 86, and so on. So now this is like thick. So after this causes basically the deterioration of the bone, the joint, and the soft tissue, the cartilage, and then there's protease also, which acts and basically destroys the cartilage, and the person experiences pain, and it also affects liver. In this, hepcidin is decreased, then is also prone to fever, and yeah, and there is certain like characteristic ones like swan neck, finger deformity, then Bottineur's dystrophy, and so on. So this is about the basic pathology of the rheumatoid arthritis. So now basically we'll go through the drugs that are used to basically treat rheumatoid arthritis. So there's a term that they usually use in the exam also, like you should be knowing that. So it's called DMARDs. So all the drugs for the rheumatoid arthritis are called as DMARDs. Now what does DMARD stand for? It stands for disease modifying anti-rheumatic or rheumatoid drugs. Okay, now let's talk about the first category. So we have corticosteroids, then second is we have synthetic DMARDs, and then you have biologic DMARDs. Okay, now we'll talk about each one individually. So in this what happens is, corticosteroids are usually given as a bridge therapy. Okay, so I'll just so they're given as a bridge therapy. They basically decrease the disease activity till slower acting DMARDs come into effect. They are basically adjuncts to the main treatment. Okay, now let's talk about the synthetic DMARDs. Now first of all, just know the names. Okay, so starting from the first one is methotrexate, then we have hydroxychloroquine, then we have gold salts, sulfasalazine, then we have minocycline, then we have penicillamine, then leflunomide. Alright, now let's talk about the biologic ones. Now in this, either you are blocking the TNF alpha, or you are trying to co-stimulate inhibit the co-stimulatory components, that is CD80 and 86. Then you are either trying to inhibit IL-6, or you're trying to inhibit IL-1. Okay, or you're trying to inhibit CD20. So in TNF alpha, you have to remember the suffix as sept, or okay. So first you have the etanercept. Okay, now in this, there's this very important drug which is infliximab. Okay, now remember in the order I'm writing only. Okay, so then you have adalimumab, then you have infliximab, on this there's this question once which is used for rheumatoid arthritis and options for this. So infliximab was the answer. Then you have golimumab, then you have sertolizumab. Now these are given as subcutaneous and this is given IV. Okay, now coming on to co-stimulatory. Now in this you have abatacept, belacect. Now they basically inhibit these CD80 and 86 on APC, antigen presenting cell. Okay, then coming on to the IL-6. Now in this you have the tocilizumab. Okay, now basic indication of this is when there is rheumatoid arthritis with methotrexate resistance, and it is also approved for cytokine release syndrome. Now this is the recent update. There is a drug called as sarilumab. Now this is a new IL-6 receptor antagonist used for treatment of rheumatoid arthritis. Okay, then IL-1 receptor, basically in this you have the IL-1 receptor antagonist, so that is anakinra. Okay, then in CD20 inhibitors you have rituximab. Now this basically depletes the B cells. It is used in combination with methotrexate. Now over here there's this thing that it can cause activation of latent TB. Okay, now this TNF alpha inhibitors, they are indicated in Crohn's disease, then psoriatic arthritis, then Wegener's granulomatosis, then sarcoidosis. Okay, now these co-stimulatory are used when the rheumatoid arthritis is resistant to TNF alpha blockers and methotrexate. Okay, and basically it can be used in combination. Yeah, then this is done. Then one question they ask is about hydroxychloroquine. This is the safest drug, like DMARD, in pregnancy. Basically, if you have to understand the treatment, so first line is methotrexate, then there is short term glucocorticoid, and this should be tapered rapidly. Okay, and then you can give the corticosteroid based DMARDs like hydroxychloroquine, leflunomide, and so on. Now if the patient is allergic to methotrexate or so, then you should basically go back to the synthetic ones. Okay, then if still there is no result, then you think about double drug therapy. Now in this you combine methotrexate and sulfasalazine. If not, then triple drug therapy, methotrexate plus sulfasalazine plus you give hydroxychloroquine. Okay, and if there's still no change, then you switch to biological DMARDs. Alright, so this is mostly about this, and then there's this question about the methotrexate adverse effects also sometimes. So we'll just write the adverse effects of methotrexate. So adverse effects of methotrexate. Now in this basically it causes gastric irritation and stomatitis, then it is hepatotoxic, causes fibrosis and cirrhosis, and it causes pancytopenia, Okay, and then there are certain risk factors of methotrexate for complications. That is, either the person is having a liver disease like chronic hepatitis, or the person is heavy alcohol consumption, then either obesity, diabetes mellitus, then kidney disease. Okay, then the other ones are that it is teratogenic, then it increases the risk of B cell lymphoma. Now there's this fact that amoxicillin and probenecid, they basically increase the risk of methotrexate toxicity. Okay, then sulfasalazine is converted into sulfapyridine, which is used for treatment of ulcerative colitis. Okay, then this lefunomide, in this basically this inhibits the DHFRAs, which is required for pyrimidine synthesis. Okay, basically it arrests the growth on B cells. Minocycline is given in early mild cases. Okay, so all of this completes most of it. Then this one more drug in this, which is teriflunomide. For this drug, you can remember that basically this is also a DHFRAs inhibitor. So this is also a DHFRAs inhibitor. The thing is, this also is used in treatment of relapsing multiple sclerosis. So this completes most of the part that you need to know about the DMARDs. So if you found this video helpful, to give it a like, share, subscribe. Thanks.